Hello, my name is Dr. Monica Flores. I'm a pediatrician in South Florida since 2001. So you have decided to become a doctor. Here are some tips on how to prepare for your journey. Your goal as a medical student and resident is to learn how to take a history, build your differential diagnosis, and learn your treatment plans. The most important, in my opinion, is taking a history. Without a good history, you can't even start the journey towards a treatment plan. Although history has been removed from the equation in billing, it's still important to document a detailed history in order to determine your differential diagnosis, what data needs to be ordered, and the risk. A thorough history will explain why you are ordering those 15,000 tests. And an excellent history may protect you in a legal dispute. Sometimes patients come in with a laundry list of symptoms. First, determine if they're all related. Does the headache come with the vomiting, or are they separate issues? Then determine which issue is life-threatening and address that one first. If none of the complaints are life-threatening, have the patient choose which one they want to address first. Most of us in the trenches have only 10 minutes to spend with a patient in history, exam, and documentation. It does no one a service when we try to address 10 complaints in that time. So break it up. Address one or two and make another appointment in appropriate time for the rest. Traditionally, the components of the history have been duration, timing, quality, severity, location, associated symptoms, modifying factors, and context. What I did as a medical student to learn to take a good history was when I was standing in the corner listening to the attending taking the history, I would write down those components on the left-hand side of my paper, and then fill in the blank as the visit evolved. Yes, I trained in the era of dinosaurs, no phone, and I still recommend my students use that method with a pen and paper when they're first learning to take a history. If using a phone in the presence of patients or attending, explain why and what you're doing, so that we don't think you're playing roadblocks in the middle of the visit. The first component of history I usually address is duration. How long has the symptom been going on? This usually leads to context and timing. Does it happen all day? More at night? During activity? Context and timing tying in with severity. How bad is it? Then quality. Wet or dry? Sharp or dull? Last, associated symptoms and modifying factors. Location is addressed by the symptom itself. Cough is respiratory. Abdominal pain is GI. The only time location is important is if it's left or right, up or lower, or the quadrants of the abdomen, etc. Now, you don't have to wait for your clinical rotations in order to learn to take a history. If you have family and friends, practice on them. Call Nana. Ask her about her high blood pressure. Uncle Ben and his knee pain. And then later, ask him what happened. How was it treated? And what was the result? This will help build confidence in taking a history. Also help build your differential diagnosis and treatment plans, even before your rotations. Before we end, let's look at a few examples from my typical day. Chief complaint: cough, rhinitis, and fever. I start my stopwatch, open the door, and say hello. And then I repeat my chief complaint. Sometimes patients sneak up on you. They tell the staff one thing and they tell you something completely different. Cough, runny nose, and fever turns into possible sexual abuse, recent sex or alcohol use, behavior issues, etc. Always be ready for the curveball. But I also try to educate my patients in those cases, letting them know that these complaints take more time. I will address them to the best of my ability, but in the future, if it's something confidential, tell the staff and they will schedule accordingly. If it truly is cough, runny nose, and fever, I ask which symptoms started first and when. If it's fever, how high? Did you take the temperature with your hand or the thermometer? If a thermometer, what kind? What was the number? 100.3 or 103.0? If they can't remember, was the 3 at the end or was the 0 at the end? Any medications they tried and did they help? Has the fever stopped or are they still with fever on the day of visit? Fever for 5 days or more for me is a red flag. What symptoms started next? Runny nose? Since when? Stuffy and runny? Color? For me, color doesn't matter. Unless it's clear for weeks, more likely allergy. Thick and green for more than 7 days, more likely sinuses. Or if bloody. I asked, is it mixed with pus? Likely sinuses. If it's just blood, maybe nose picking or leukemia, possible bleeding disorder. Last, I address the cough. Since when? Dry or wet? Does it wake them up at night? Make them throw up or gag? Worse with activity? Any wheeze, chest congestion, or shortness of breath? Any medicines given? How often? And did they help? On this, I'm very particular, especially if they're doing breathing treatments with albuterol. Most patients will tell you that they're doing the breathing treatments every 4 hours, but then I ask them to clarify when was the last time they did it, and are they doing them through the night? In reality, most people actually do their breathing treatments only once or twice a day. Last and most important, did it help? Comfort in knees and taking the history comes only through practice, practice, practice.